So, hi, good evening, everyone. So, we welcome you today for this session of Neurocritical Care Society of India, which is on neurosonology. Thanks for watching our videos. Thanks for appreciating, sending additional comments, and also giving ideas for future seminars and topics. We suggest that please be a society member for Neurocritical Care Society of India, support the society, and be a very active part of the society. So whatever you want to present or you wish others to present, you can suggest the topics to us. And for today, we have this module 2 of neurosonology series, which will deal with traumatic brain injury, SCX stroke, and also about brain death. And we are very glad to welcome our expert for this session, who is very meticulous and he has been doing neurosonology and great practitioner of neurosonology. And that's Professor Vincenzo Ishingolo, and he is neurologist and head of stroke unit at in Italy. I don't want to say the hospital because I may mispronounce it. So, and Pramod has been with him for some time, and he's his mentor. And we thank you. We extend our gratitude for joining this session today, Professor Vincenzo. A very good evening to you.
Thank you. Thank you for
Yes.
invitation to this webinar.
Thank you so much. Thank you. And from here, I hand over to Rajiv, who is going to introduce the speaker. Rajiv is our moderator for the session today, and he is our faculty of neuroanesthesia, neurocritical care from NIMHANS. And over to you, Rajiv.
Thank you, madam, for this wonderful introduction and start of the session. I welcome all again to this Neurocritical Care Society of India webinar. This is part 2 of neurosonology. To host the session, we have two eminent faculties. First one is our speaker, Dr. Pramod Kalgudi. He is assistant professor in MS Ramaiah Medical College, Bangalore. He trained from NIMHANS only as DN student. Then he got Neurosonology Fellowship under mentorship of Professor Vincenzo in Italy. And now he's going to deliver the part 2 of neurosonology, how the use of TCCD in various neurocritical care settings. I welcome Dr. Pramod. And our expert here is international expert, Dr. Professor Vincenzo. He is the current head of stroke unit in neurology department in Casa Sollievo della Soffrango Hospital in Rotondo, Italy. He has a lot of numerous achievements to his name and accolades to his name. His vast experience in this field, and I'm sure with this, with his help and and Dr. Kalgudi's help also, we will get to know the insights of neurosonology better, and we can uplift our skills in this area. So I welcome you both, and let us start the session. I hand it over to Dr. Pramod to start the session. Thank you.
Thank you, sir. Thank you, Ashishman, for giving me this opportunity. So today we'll be talking about use of neurosonology in TBI, stroke, and SAH patients. Short disclaimer, a special regards to my teachers, Enzo and Michael, and I do not have any conflicts of interest. So we'll start off this session looking at a normal spectrum, Doppler spectrum, and what are the velocities and how do we measure the velocities, and what is pulsatility index and resistive index, and so on and so forth. And then we see how do we utilize TCCD in traumatic brain injury, stroke, and subarachnoid hemorrhage patients. To look into the normal spectrum of a patient stopped cranial Doppler. So the first thing what we do, we insulinate MCA and we measure the MCA velocities. So the topmost velocity point, that is 1, indicates peak systolic velocity. The point 2 represents end diastolic velocity, whereas the slope of this curve represents the acceleration time for the peak systolic velocity to be achieved. And 4 indicates the duration of time needed to achieve that peak systolic velocity and with the acceleration that is called acceleration time. So you can see a green line across the spectrum on top, which tells you a time average maximum velocity. And you can see a blue line beneath, which tells you time average mean velocity, which is more or less equivalent to mean velocity in TCD. So the next part is the calculated indices, that is the resistive index and the pulsatility index. The resistive index is calculated using the formula of peak systolic velocity minus end diastolic divided by the peak systolic. But if you divide it with the mean velocity, you get the pulsatility index. You can also calculate the mean velocity with the formula of 1/3 of peak systolic minus end diastolic plus end diastolic velocity. So if you would ask me which of these indices is a better indicator to measure the intracranial resistance or a peripheral resistance, I would say it's pulsatility index. The reason being, it takes into consideration the mean velocity, which takes into account of an entire cardiac cycle, let alone taking the peak systolic velocity like that of a resistive index. So it takes into account the compliance as well as the entire cardiac cycle. So that makes it more reliable to depend upon or to have a good correlation with that of a peripheral vascular resistance than the resistive index. And most of the literatures we have is based on the pulsatility index. And even in the most research paper, it's the authors to represent pulsatility index as an indicator for peripheral vascular resistance. When we look at the Spencer characteristics of Doppler spectrum, we always have some stenosis at some point. And when we put a Doppler here at this point, we see a stenotic flow. You can see a peak systolic and then sudden deceleration at this point because of an intrastenotic flow. But we see this sort of patterns in pre-stenotic. So you can see the flow velocity reduces and the PI increases because the diastolic flow reduces and the peak increases. So as and when the diastolic flow starts reducing, you can see the PI increasing. The opposite goes good with the post-stenotic segments. The early post-stenotic segment will generally have too much of a turbulence. So you will see a wide spectrum of Doppler in this region. Whereas little distant to post-stenotic region, you see some sort of a dampened flow. This is the stump flow before the stenosis. You see a dampened flow, which look just like a camel's hump. So here the flow velocities decrease. With that, the PI also decreases because both peak systolic and diastolic velocities have reduced. So let's discuss uses of TCCD in traumatic brain injury. To start off with, it plays a very important role in managing patients acutely when essential at bedside, especially in patients with severe TBI. And it helps us to estimate non-invasively the intracranial pressure and also guide us to administer osmotherapy in these patients. Let alone diagnosing traumatic vasospasm and hypoperfusion, it also helps us to screen post-traumatic internal carotid artery dissection, and we can also titrate our therapy based on the assessment of autoregulation using TCCD. None of the guidelines, unfortunately, haven't included TCD or TCCD based therapies or diagnostic modalities in the guidelines for managing TBI patients, uh, except the French national guidelines. So, why do I want to do TCCD in a patient with severe traumatic brain injury? So, a study done in 2017 showed that on an admission, if the pulsatility index is greater than 1.4, with an end diastolic velocity of less than 20, the mortality rate is 98.6. That's tremendous mortality if the patient comes with uh, such a Doppler spectrum. So it's quite an important tool for us to diagnose such patients at an early stage and probably start acting. So let alone diagnosing them at that stage, you can also treat them with osmotherapy. And these studies have shown that osmotherapy based or TCCT based osmotherapy have reduced the mortality in these patients. So how do they diagnose when do have they have to initiate the osmotherapy was when they found two of these three. That is, whenever the mean flow velocity was less than 30, and end diastolic flow was less than 20 centimeters, less than 30 and 20 centimeters, and the PI of greater than 1.4. Keep in mind that these things have to be done after optimizing the end-tidal carbon dioxide or the PaCO2 and the MAP, that is after resuscitating the patient adequately. It also helps us to predict the patients who come to us with mild to moderate severe or mild to moderate TBIs. All of us who are working in the intensive care units might have seen patients who were talking in the morning but pass away at night or later in the evening because of sudden increase in the ICP or worsening of neurological condition due to secondary brain injuries. So how do we anticipate such injuries happening in patients with mild to moderate TBI? So you do the TCCD and look for pulsatility index and end diastolic velocity. If it is 1.25 and the EDV of less than 25 centimeters per second, will predict that the neurological worsening in these patients is expected to happen in next 7 days. To give you an example, this is a patient with severe hypertension, 48 years old, came in with severe TBI. So on admission, this was the Doppler spectrum of this patient with the pulsatility index of 1.3 and end diastolic velocity of 21. So after resuscitating the patient, we started off the patient with osmotherapy, and with that we could see that the end diastolic velocity increased to 34, whereas the PI dropped to 0.89. Eventually, this patient ended up having worsening in the neurological status and underwent decompressive craniectomy. And you can see what happens to Doppler spectrum in the decompressive craniectomy patients. The pulsatility index drops, and you see a wide spectrum of the velocities in the MCA. That's because the compliance improves and the ICP drops, and the resistance reduces drastically, which helps the vessels to open up. And that's the reason why we see a wide and broad spectrums in these patients. This is a second case. A 38-year healthy patient comes in with a TBI. On the right side, he had an EDH with a scalp hematoma. So we could not do a TCCD from the right side. So instead, we did it from the left. And when we saw prior to the surgery, I could not visualize much of the MCA on the opposite side. And the same was to be seen in the same patient after he underwent EDH evacuation. So the surgeons were a bit reluctant in starting off any osmotic therapy in this patient, considering the risk of recollection of EDH immediately post-surgery after administration of any osmotherapy. But the patient, if you see, the MCA velocities on the opposite side were present, whereas only on the right side, we could appreciate it only after starting the osmotherapy in this patient. That tells us that there was already an underneath secondary injury which has started occurring in that patient in spite of evacuation or much before evacuation, which would present to us later on with no MCA seen on that side. And with the osmotherapy, we could insunate the MCA and we got the spectrum. Speaking of non-invasive ICP, why do I have to measure ICP non-invasively? So I would tell you that's because the intraparenchymal catheters measurement have a drifting mechanism through which you cannot calibrate once you insert it. If your patient has any sort of post-trauma coagulopathy, you would end up delaying the insertion of an invasive catheter. And it's always a cumbersome in an institute where you have a busy neurosurgeon or a resourceless center to get an ICP catheter. So obtaining these logistics would take at least some 2 to 3 hours. So while we do all this, it potentially delays the treatment for the patient. So TCCD being a point of care uh, instrument and tool for us, it's been used along with it, just like TCD since 1987 to measure ICP non-invasively based on the pulsatility index, based on the formulas used for CPP, and also based on mathematical models. Yes, if you ask me, do you accept it? Yes, I do. Why? Because there has been enough evidence so far that there is a good correlation of measured ICP, then overall accuracy of plus or minus 12 millimeters of mercury. And these estimates have good correlation with the ICP values. So there are a few formulas which you can see on the screen, which can be used to calculate CPP and non-invasive ICP using the pulsatility index as well. This non-invasive ICP measured using different formulas or using PI, especially using cerebral perfusion pressure formula, has shown to have 100% sensitivity in excluding any intracranial hypertension defined as more than 20 mm mercury. We have to keep in mind whenever we are looking at pulsatility index, there are plenty of factors which can affect it. So we might have to take care, especially of the carbon dioxide, and then with anemia, and then any certain high cardiac output regions or any arterial hypertension. So these are the most common things which can reduce the ICP, reduce the pulsatility index, whereas certain conditions like hypocapnia or increased viscosity or any sort of regurgitant lesions would increase pulsatility index. When we look at using TCCD in patients with to diagnose post-traumatic internal carotid artery dissection, it's been advised by European Eastern Association of Surgery guidelines to screen patients whenever we have a blunt trauma, whenever we suspect a blunt trauma in the patients. And they have gone on to say that if there is any asymmetry between the peak systolic velocities between both MCA of more than 25%, and if you see a pulsatility index of less than 0.8, and if there is a demodulated velocity waveform that correlates well with ipsilateral traumatic carotid dissection. This is a case of case which we encountered a couple of months back. 2-year-old child fell accidentally from a first floor and ended up developing left frontal SGH, and the child underwent emergency decompression because of drop in GCS. But post-surgery, the CT scan was suggestive of infarct on the right ACA and MCA territory, which was quite surprising for the surgeon. And surgeon just called me at night and just asked me if you could just have a look at the child and see what's wrong. So these were the baseline prior to the surgery. This was the PI of the child on the right side, and on the right you see the PI of the left MCA was around 0.57. The peak systolic flow was around 92 and 109. Though there was not significant change, that is more than 25% prior to the surgery, we didn't suspect any dissection. But when we did CV Doppler in this child, we could see that the internal carotid artery was completely almost stenosed because of it might be because of query dissection, which has extended into the almost up to the intracranial part. So you can see the Doppler waveform, which looked like a stump waveform, and also a spontaneous echo contrast because of too much of turbulence near the ICA. And the MR angio was correlating the next morning. The child literally didn't have the ICA on the right side because of complete dissection. Apart from using it to screen dissection, it can also be used bedside to assess the autoregulation capacity, that is to do autoregulation tests. One of the tests being transient hyperemic response test. So this test can be done bedside using the MCA flow velocities. So you need to insunate MCA velocities throughout during this procedure. So what you do once you insunate the MCA, you occlude the ipsilateral extracranial carotid artery to 5 to 8 seconds and then release it. So you observe the change in the velocity of your MCA after you release the compression, and you take the ratio. The ratio has to be more than at least 1.02, or you have to see the peak systolic velocity increase of more than 10%. So the disclaimer being, you always have to screen for carotid plaques or thrombus and never prevent them from dislodgement if you are compressing too much. So in this spectrum, you see I compress the carotids here, and you can see a flattening waveform going ahead. And then once I release the compression, you can see a peak systolic velocity of the next waveform. So you measure this waveform's velocity with that of the waveform just before the compression. You can see it is around 80, and the post release of the compression is around 120, which is more than 10%. So this is an intact autoregulation. Let's speak about optic nerve sheath diameter. So how do we measure an optic nerve sheath diameter? This is the latest guidelines, the POCUS QCC, that is ONST POCUS Quality Criteria Checklist, released in 2024 October. It gives a brief elaboration of a checklist, what to use and how to measure an ONST. The probe which is generally used is a high frequency probe, that is a linear probe, that is 7.5 megahertz probes. And sometimes we use ocular preset if it is available. If it is not, what we have to do is we have to make sure that the mechanical index and the thermal index have been achieved. So how do we do that? We follow the ALARA criteria. So mechanical index of less than 0.23 can be achieved by reducing the power in your Doppler, and the thermal index would be less than 1 if you try to measure it as quickly as possible, less than 5 minutes. So apart from that, do you have to sanitize your probe? Yes, you have to. Do you have to put an envelope, or do you have to put a cover to cover it? No, it need not be. They say it's at the discretion of the clinician, but it is essential that it is must that you should sanitize or disinfect it, or disinfect your probes before using. And it's hard to keep a patient's case neutral in patients who are admitted in the ICU. Apart from that, imaging techniques, it is advised to measure an axial view, that is the transverse view for imaging, rather than an vertical view. Because and then which image do you have to prefer? It's the most clearest image where you can differentiate between an optic nerve and not an optic nerve sheath. There is no hard and fast rule that your optic nerve sheath has to be measured at the midpoint cross-sectional level or at the retinal artery or venous level. You will have to have an image which shows you to demarcate the optic nerve and optic nerve sheath. So that is the one through which you can measure. When we look at measurement, it's always at 3 millimeter behind the retina, and a line should be drawn perpendicular to that line which is drawn 3 millimeter behind the retina on the optic nerve. And remember that the angle has to be 90-degree whenever you have put the cursor on. So let me show you some images. So this is an optic nerve sheath diameter. Here, in spite of measuring it at the midpoint level, I could still appreciate the optic nerve sheath and the optic nerve internus. So you measure the internal one, not the external diameter. That is the optic nerve sheath diameter. So in this patient, it was around 0.61 centimeters. So apart from discussing optic nerve sheath diameter and PI, these things have been lately inculcated in Brussels consensus for non-invasive ICP monitoring whenever we don't have an invasive ICP monitor, especially in patients with TBI. So this is the latest algorithm and the guidelines, consensus statements and recommendations. I would just briefly go through the strong recommendations which are given in these guidelines. So it is said that the threshold for to say that the ICP is abnormal has to be defined by doing TCCD and ONST both. And once you find that non-invasively the ICP on TCCD is based on the formulae of CPP, if it is more than 20 to 22, or ONST on any side is more than 6 millimeter, or pulsatility index greater than 1.3 with a flow velocity of less than 20, and increase in ONST from the basal value. So this is a very important thing, to always measure a basal value. If there is an increase by 0.5 millimeter on any side, that tells you that that's an abnormal ICP. And then if the increase in PI from the basal value is 0.5 on any side, that also tells you that there is an abnormal ICP. Let's see some weak recommendations. These recommendations tell us when exactly do we have to repeat the TCCD or ONST in patients with severe traumatic brain injury. So the time duration is at least between 2 to 4 hours. And in mild to moderate traumatic brain injury patient, it is advisable to do it every 4 to 6 hours. With that, we would go into the aneurysmal SAH and how do I use my TCCD in aneurysmal SAH patients in ICU. So most of the time, it's not a diagnostic tool. It would just help you or aid you in identifying structures and looking at certain, making certain decisions at the bedside, and also in treating, in detecting vasospasm and hydrocephalus. So is it possible to identify an aneurysm? Yes, it is. So when we look at these images, you can see an aneurysm in the ACOM region. This is the ACA and this is the MCA here, and this is the aneurysm in this part where it looks blue and red. Whatever is blue is towards the probe, away from the probe. Whatever is red is towards the probe. So why does it look red and blue on TCD? I'll tell you in the next few slides. So this is an example of basilar top aneurysm. So you can see a blue and a red uh, on the color Doppler. So this is the PCA, you can see here. This is the mesencephalon. All the images are done in the mesencephalic plane, more or less. So this is the vertebrals joining into basilar and coming in between the mesencephalic at the level of pineal gland, behind the pineal gland. So this is next, the MCA bifurcation aneurysm. So whenever we start doing the TCCD, we generally have to track the vessel all through its entire course, so that to make any diagnosis or any inferences, it is advisable to track the entire vessel. So if you keep observing this, so you will see some sort of blue and red, and then I trace it back towards its origin. So this is an MCA which is going into the MCA bifurcation, but at the bifurcation, I see something red and blue. So that tells me that that is the aneurysm. So how do I confirm it? When I put my Doppler, pulse wave Doppler, I will see a waveform in a bidirectional way, because in an aneurysmal sac, the blood flows haphazardly in multiple directions. So you see sometimes the blood going towards the probe and sometimes away from the probe. So that's the reason why you see a blue color when it's away from you and red color when it's towards you. Apart from just looking at the aneurysm, you can also see after the coiling or any interventions how exactly the intervention went. So if you can see the aneurysm, this is the aneurysm here. Post coiling, we couldn't see any rest. We could not appreciate any residual flow in the aneurysmal sac. So this also helps in diagnosing if there is any residual flow in the aneurysmal sac. Apart from that, the vasospasm is one of the most important things to be aware of, should be aware of, and this is very detritus to the patients. So we can diagnose vasospasm with the TCCD much better than with any other modalities at the bedside, because TCCD has an ability to scan each of the segments if they are visible, to diagnose if there is any particular segment which is vasospastic, and the color mode would probably hint you with an aliasing effect to tell you that yes, there might be some vasospasm at that point, and it is easy to keep repeating it more often to see if the progression or regression of vasospasm. So this is a patient of ACA ACOM aneurysm post coiling. This patient had developed ACA spasm, so the peak systolic velocities went up over 200, and the Snollen's index was greater than 4, which is measured by with the ratio of extracranial ICA. And you can see the aliasing effect on the bottom right, where you can see the red and blue overlapping with each other. That tells you that there is some amount of spasm at that region. The Lindegaard's ratio, been established since 1988, tells us to differentiate vasospasm with that of hyperemia with different values. Keep in mind, these values have been derived from TCD. So all these values which you see, the mean velocity of greater than 120 in the anterior, greater than 80 at the 80 to 85 in the posterior circulation, are all based on the TCD research and TCD literature. So you might have to keep that in mind whenever you're using TCCD and correlating those velocities with that of the TCD velocities. And keep in mind, if there is sudden increase in PI of 1.5 throughout multiple vessels, that tells you that the ICP has risen tremendously at that point. And the critical value to diagnose is whenever there is an increase in mean of more than 50 within a day, or increase by 25% within a day, tells you that there is a critical spasm in such patients. So we all use this chart to treat our patients in the ICU. So we have, and whenever we encounter vasospasm, our patients fall into bottom of this table. As we keep treating them, the patients go up the ladder and we achieve the normal spectrums in these patients. So this is just a correlation to show you how a severe vasospasm while after the treatment would reduce the Lindbergh's ratio along with the velocities. The other index based on the latest study is that arteriovenous index, which tells you that vasospasm can still be diagnosed with a good sensitivity and specificity if we divide the MCA flow velocities with that of either mean or peak systolic velocities of vein of Rosenthal. So AVI index of greater than 12 is suggestive of vasospasm. Apart from just diagnosing vasospasm, we can also diagnose patients who develop hydrocephalus secondary to SAH. So this is an example where the pica aneurysm patient developed SAH with hydrocephalus, where we could see the third ventricular diameter was greater than 10 millimeter and the ONST was significantly high, which was more than 6 millimeter. Let's see what can we use the TCCD, how can we use TCCD in patients coming with strokes to our ICU. The disclaimer being, if the patient has come to us before the thrombolysis and if the patient is in window, it's advisable not to waste time doing TCCD or TCD at that point. And it's, as we know, the time, as we know that time is brain. So is there, we have to, what other things can we look at when with the TCD or TCC, especially with the TCCD in patient with stroke? So as soon as we get the patient, we have to look for any evidence of extracranial atherosclerosis in the carotids or vertebrals. And then we can also monitor for post-thrombolysis, whether there is a reocclusion or hyperperfusion. We can monitor for microembolus signals and also look for indirect signals, that is evidence of collateral blood flow. So these are the examples of different plaques. You can see a plaque has completely obstructed the flow in the ICA in the patient. And there is some amount of atherosclerosis and also a plaque on this patient here on the right. So we can also assess the vessels in the cross-sectional view, that there is no, we can appreciate that there is no flow in the ICA, whereas there is some flow in the ECA in this patient here. If you look at this plaque, this is a plaque which is arising at the bifurcation and extending into the internal carotid artery. The plaque has extended into the internal carotid artery and causing stroke in this patient. Apart from that, you can see the characteristics of this plaque being hyperechoic and it's not transmitting any signal beneath this. So that is an example for calcified plaque. Just like TB grading, which we all are aware about, which is based on the TCD or a TC grading, there is something called as COGIF grading, which is consensus of grading intracranial flow obstruction, which has a good correlation to to estimate the stroke severity, recovery, and mortality like that of TB. And whenever there is no improvement in the residual flow, which correlates that the patient can have worsening, or there is poor recovery, or there is increase in mortality in such patients. Just excuse me. So COGIF grading will tell you that what is the flow pattern in the post-stroke patients. If there is no flow, it is grade 1. If you see some amount of diastolic, systolic flow without any diastole, it is grade 2. If you see very little flows with bit of a diastolic flow, then it is called grade 3. And grade 4 is differentiated into A, B, C. A being a normal spectrum, and B and C shows you that there is amount of stenosis or some hypoperfusion at segmental level. So if you correlate that with TC or TB grading, you can see the grade 1 and grade 2 are more or less combined with grade 0, where there is absent flow. And TB grading of 1 and 2, you can see 2 is COGIF grading correlates with TB1. Here there is no zero end diastolic velocity. When the end diastolic velocity increases more than 0, it goes into COGIF 3, whereas it's still TB2. And if there is increase in end diastolic velocity, and if the mean is decreased greater than 30%, then the contralateral, it goes into COGIF 3. whereas in 4ABC, it is TP 4, 4, and 5. So the normal flow in TB or TC grading is 5, whereas in COGIF it is 4A. So what does it tell us? So let's say the patient with grade 4 is with us. That tells us that this is a normal spectrum and there is complete recanalization of the artery. If a patient with grade 3 has improved to grade 4 or from grade 2 to grade 3, that tells us that there is partial recanalization. So if there is any increase in one grade, there is partial recanalization. And if there is no change to that of a baseline, then we have the same grading. If the grade decreases greater than or equal to 1, that tells that there is some worsening. So this is a young female who was on oral contraceptive pills, came in with a history of stroke, and when we did the TCCD in this patient, we found that the MCA velocities on both the sides were more or less equal, and the TB or the COGIF grading was 4A. When we looked at the neck Doppler, there was a hemodynamic, there was a dynamic plaque in this patient, dynamic thrombus in this patient. And eventually, 6 hours later, patient complaining of started worsening weakness and the GCS dropped. And when we did the TCCD, we could not visualize the MCAs anywhere beyond this point. So she dropped her COGIF grading to 1 straight away from 4A. So that's a worsening of an infarct or a stroke. Apart from looking at direct signs of occlusion, there is a concept called flow diversion, which tells us that what is the flows in the collaterals. So this will tell us if there is any increased in flow velocities of the AC and PCA. For example, if the MCA is occluded and there is ipsilateral increase in AC and PCA, that tells us that there is good flow diversion to compensate for the stroke to keep the brain not going into infarction. So the cutoff for this is either a discrepancy over 30% has been found to be a good predictor for flow diversion having a good outcome, especially in case of MCA strokes. So this is the same patient who had an increase in ACA territory flows, which was around peak systolic flows was around 117. So let's see what happens exactly in all these patients if they become brain dead. So either a TBI, SAH, or a stroke, patient can present you with a dead brain. So what happens in brain death? So this is a normal flow in a patient where the ICP is less than 20. As the ICP starts progressing beyond 20, it starts going above your diastolic pressure. So you can see the spectrum, the diastolic flows are very well seen here. So the diastolic flow is compromised in this region because of raise in the ICP. But CPP will still fight for it and try to perfuse the brain. And this is a last tombstone where you have an opportunity to revive the patient from here on. So if you see such type of a waveform, that tells you that now the ICP is almost equal to diastolic blood pressure. So now your systolic blood pressure is alone fighting for it, fighting to revive your brain. So if you do not intervene at this point, the patient would die. The brain would die. So what happens if you go beyond this? So the ICP, if goes beyond the diastolic flow, then you see the diastolic reversal at this point. So there you see a to and fro low velocities. So the mean velocity would be less than 4 centimeter per second. And if the ICP goes on increasing beyond this systolic velocity, so you just see sort of systolic spikes where the peak systolic velocity is less than 50 centimeters and with a duration of less than 200 milliseconds. And if it goes beyond that, you don't see any flow. So this is a spectrum of a patient with the normal flow who can become brain dead as the ICP increases. The other sign for brain dead is to appreciate flow reversal in the basilar artery. So in the basilar artery, you can see it's a suboccipital window where you can insinuate the basilar artery. You can see the flows in the basilar is always away from the probe. So you see always a negative spectrum in case of basilar flow. So if whenever you see a positive spectrum in a basilar flow, especially in case of brain dead, that tells you that there is a flow reversal in basilar artery as well. So what is the proof that these patients are having cerebral circulatory arrest? So the disclaimer being, this is just an ancillary test. This is not a definitive diagnostic test. The different guidelines have a different parameters into consideration, take different parameters into consideration to diagnose brain death. So when asked, registration of oscillatory or systolic spikes in most of the vessels is required, but it is essential to do it at least in the MCA bilaterally and in the basilar artery to avoid false positive results. And the time interval being 30 minutes minimum to confirm irreversibility of the pattern. So with that, I guess we would learn to incorporate TCCD as a point of care dynamic tool and start doing scans much early as and when the patients come to ICU and repeat it frequently, combining it with our clinical examination and neuroimaging, and communicate our findings to neurosurgeons and neurologists to treat the patients better. Thank you.
Thank you, Pramod, for this lucid talk presentation. It was really nice. Yeah, I would like to ask few questions, but at the end of all the talks, once both of you are finished, yeah, we will
Sure,
ask
sir.
few questions.
I would
Yeah,
like
now
Enzo to.
yeah,
I'd like
Professor
Enzo
Enzo.
to discuss few case scenarios with us.
Yes. Professor Enzo, yeah, correct.
Yeah, I have the audio now. Okay. Can I ask you something or not now?
We can do that now, or we can do it at the end
Or we
after.
can start with my case?
Yes.
Yeah.
Okay. Okay. So now it's a on presentation. It's clear. Do you see my presentation?
Not yet.
Not yet.
Pramod, yours only.
No. Ashish, ma'am,
Yeah.
could you?
Now we can
Yes,
see your screen.
yes, we can see the screen now.
Oh, okay. Just a moment. I am online? I'm online?
Yes.
Yes.
Good to go.
Okay. Good evening, everyone, and thanks so much for inviting me to this webinar. My first case is a 40-year-old Asian man without relevant risk factors, no smoker, no drink alcohol or use drugs, and he came to the emergency room because he had noticed his right hand getting steadily weaker over the past 3 days, and the last few hours he had started having trouble speaking also. In the emergency room, he had a non-contrast CT scan, which looked normal, as you can see, and NIH stroke scale was 3, and his ECG was normal. He was admitted to our stroke unit without any further acute intervention, since there were no indications for thrombolysis or thrombectomy. So in stroke unit, we performed the carotid and vertebral Doppler, but that were normal. And on TCCD, we saw a focal aliasing zone, as you can see here in this clip. And this is a focal aliasing zone, and about 5 millimeters on the left MCA M1 with the accelerated flow. You can see here a peak systolic flow of 300 centimeter per second. And now this is the post-stenotic flow with a pattern of low velocity and low resistant pattern, maybe for vasodilation in the distal segment of the circulation. But another, this is the right MCA, normal. But this was another issue. This is a pattern with two microembolic signals. And this is an important issue that we can discuss later. And after this, this is in the acute phase. This is the main characteristics of microembolic signals on TCD, but also on TCCD. High intensity spikes are have short duration, and random time occur unpredictably throughout the cardiac cycle, not synchronous with the systolic peaks, and have a distinctive audible chirp or click. During the recovery in a stroke unit, he underwent also a MRI with the DVI that show this lesion, as you can see. And sorry. Just a moment, please. Do you see my presentation?
Yes, we do. We do. You can put on slideshow.
Yes.
Okay.
Now,
This
yeah,
is good.
Okay.
Very
Okay.
good. Yes. Thank you.
And in this was the pattern on the right side of MR angio, and this is CT angiography with the same pattern, with the intracranial left MCA M1 stenosis. And this is the imaging comparison with, as you can see here, the stenosis in CT scan, the angio CT scan, and this is the MR angio, and this is the pattern in TCCD. The diagnostic workup in stroke unit was also with a complete cardiologic and evaluation that was normal, thrombophilia and screening, and also this was normal, and genetic test for Fabry disease not ongoing but normal, also normal. So the diagnosis was minor stroke with the NIH stroke scale 3 at admission. Etiology is clear, intracranial stenosis of left M1 atherosclerotic, but I don't know if atherosclerotic or of the other origin. But we have no other predisposing causes identified. The treatment in a stroke unit was the management in stroke unit, and 3 months of dual antiplatelet therapy with a loading dose on the first day, then clopidogrel, only clopidogrel with 75 milligram daily, and atorvastatin 80 milligram daily for 3 months, then 20 milligram daily, and also physiotherapy. At discharge, after 5 days, the symptom improvement was clear. There was NIH stroke scale of 2, only with a drift of motor of right arm and a mild aphasia. And neurosonological evaluation was normal and without change in stenosis, but no mass were relieved. Neurosological follow-up at 1 month. It's interesting because there is a reduction of resistance index in territory distal to the stenosis. And this is a compensatory vasodilation, and also a flow diversion from posterior circulation. In fact, you have increased velocity. You can see here the PCA, the increased velocity of homolateral PCA through leptomeningeal collaterals. The follow-up, the follow-up was at clinical and neurosonological evaluation at 2 weeks, 1, 3, and 6 months, evaluating symptoms, stenosis, and microembolic signals. At the most recent follow-up, the neurosonology findings are unchanged, and his neurological deficit is nearly resolved. He's still on clopidogrel and atorvastatin. These are, in my mind, some points of discussion, and demographic shifts have increased in our regions, the presence of people from Asian countries. And intracranial stenosis are more common in Asian populations. And relevant also is the prognostic significance of microembolic signals, and multidisciplinary approach. It's essential: neuroradiology, stroke unit, neurosonology. And there are also key questions like indication for endovascular interventions, optimal double antiplatelet therapy duration. Okay, thank you for your attention. This is the first case, and I can go on the second case. The second case is this one. This is a case of idiopathic intracranial hypertension. This is a condition characterized by an increase in intracranial pressure without evidence of space-occupying lesions or hydrocephalus. It affects predominantly young overweight women, and presents with chronic headache and progressive visual impairment due to papilledema. Our patient is a 26 years old, slightly overweight, with a history of endometriosis and currently on estrogen progestin therapy. For 3 months, she has suffered from diffuse headache and progressive blurred vision with photopsias. At initial evaluation in the emergency department, she showed no neurological deficits at bilateral papilledema and at fundus oculi and bilateral peripheral visual field constriction. And the point of care neurosonology in our stroke unit, the patient was admitted in our neurology department, and with point of care neurosonology we were able to examine orbital ultrasound and transcranial color code Doppler. At the orbital ultrasound was clear the optic disc elevation bilateral, 1.9 millimeters and on the left and 1.6 millimeter on the right. And there was also an increase of optic nerve sheath diameter. And on transcranial color code Doppler, TCCD, flow reversal in the left middle cerebral vein, and in reversal flow direction also in the right transverse sinus. These are the neurosonology findings. With the orbital ultrasound, we can see here the papilledema, the optic disc elevation. This is the increased optic nerve sheath diameter. And this is the cerebral veins, reverse flow in the left middle deep cerebral vein. You can see here, this is the artery, middle cerebral artery, MCA, and this is in red the vein that usually is blue, and in this case is red, and this is the same on the spectrum, not away from the probe, but in front of the probe, because this is the normal pattern in the middle deep cerebral vein. You can see here the flow away on color and also on spectrum, away from the probe. This is normal, and this is that of our patient. This is the reverse flow in the right transverse sinus. This is a examination during administration of SonoView, the contrast medium ultrasound for ultrasound, but it's not mandatory the use of SonoView. In this case, we use the SonoView, and you can see here the pattern. This is the contralateral transverse sinus that is red, so is on the opposite side is also this one, and this is the normal pattern that of the transverse sinus, blue, and this is the red pattern, abnormal. This is a neuroradiological imaging, MRI with contrast, venous study, and also the study of venous flow with the CT scan. And you can see there are no parenchymal lesion or hydrocephalus, and there were signs of intracranial hypertension, like empty sella, optic nerve tortuosity, and the MRI showed a focal stenosis of left transverse sinus, and you can see here the tortuosity of optic nerve. Here, particular. This is the stenosis of right transverse sinus. Here, you can see here. And this is the reason, because we can see in TCCD the flow, the reverse flow here. Here the flow is not on the jugular vein, toward the jugular vein, but toward the torculare overofilo on the opposite side. The management of this patient was medication adjustment, discontinuation of estroprogestin therapy, initiation of acetylzolamide treatment with a rapid improvement of headache in a few days. And we decided against lumbar puncture and angiography due to the rapid response to medical therapy. The follow-up, this is the follow-up. There are the ultrasound findings at a 3-month follow-up here. You can see here normal at 3 months, complete symptom resolution, and also normal optic disc. Here you can see 0.8 here. And you can see also normal optic nerve sheath diameter. The diameter is now 5.2 comparison with the 6.2 of the first stage. Interestingly, at 9-month check, we observed normalization of flow direction in the right transverse sinus. There were always normal at 9 months, always free of symptoms, and at 3 millimeters of depth. You can see here the measure of 5 millimeters, the optic nerve sheath diameter that was normal. And also normal optic disc elevation, only 69 millimeters. And this is the transverse sinus, now orthodromic, not more antidromic, but orthodromic. And these are points of discussion. First, the diagnostic value of a neurosonology, orbital study, and TCCD study that enables rapid bedside detection of raised ICP and venous flow abnormalities. And the clinical correlation, it's important because transverse sinus stenosis in this case may be primary or secondary, and imaging must be correlated clinically. And POCUS benefits. POCUS Orbit is a non-invasive, cost-effective tool for monitoring treatment response. And important also the team approach, the multidisciplinary approach is vital for timely diagnosis and management. These are my conclusions and take-home points. So early use of neurosonology accelerates IIH diagnosis and guides therapeutic strategies. Effective treatment, acetazolamide is effective for rapid symptom relief in responsive cases, and monitoring regular neurosonologic follow-up ensures safe tapering of therapy and visual protection. And this is my conclusion. Consider POCUS in neurology as an extension of your clinical skills. Thank you for your attention.
Thank you, Professor Enzo. It was a nice presentation of these two cases. So we will discuss few questions. I will ask few questions to Dr. Pramod, and as well as Professor Enzo also can help us in that regard. So I have few questions on with regard to estimation of non-invasive ICP using TCCD or TCD. The problem with the PI, what is the problem with the PI based formula, or the problem with the CPP estimated CPP formula? Dr. Pramod, you can answer. Unmute yourself.
Hello.
And yeah.
Am I audible?
Yes, you can go ahead.
So more often the PI-based formula would give you a value, either it is overestimating most of the times, and the CPP-based formula has a well-established literature review on the CPP-based formula. And if you just ask me, if you just take PI as a consideration, PI would definitely be an indicator, better indicator over RI. But if you're incorporating it in a formula-based technique, I would still go with the CPP-based formula for a non-invasive monitoring. And if Enzo can add on to that, if he has any.
No, please.
I would like to add something like PI,
Yes.
the maximum PI possible in a case would be 3.
Yes.
Okay, there is a limit always. So PI based formula would give you a limited ICP values. Maybe if you calculate, it will be like 30, 31.
30, yes.
You cannot get more than that if PI is 3. Similarly, CPP based formula, the problem with the end diastolic flow velocity, the diastolic velocity. If the diastolic velocity approaches towards 0,
yes,
in that case, the ICP is through the roof, but your formula will get to you only a 14 ICP.
Plus 14, plus 14.
So these are the problems with the formula. So you have to see your EDV as well as the PI to determine the ICP better. Yeah, morphology. Best is the morphology.
Morphology.
Yeah. So again, one more point here I want to add is more dynamic methods of autoregulation should be used. For example, you have shown transient hyperemic test, okay, as a part of cerebral autoregulation. But I would like to say calculation of mean flow velocity, mean indices, flow indices using TCD and the blood pressure using a frame is a better indicator, and continuously you can manage. Am I correct, Professor Vincenzo, in this regard? More dynamic assessments.
Yes. Yes, I agree.
So,
there are some issue about the quantification of the monitoring of vasospasm in a patient with the subarachnoid hemorrhage regarding the angle.
Angle correction,
can you promote?
I can answer that.
So something else, because you described the problem of the angle during your presentation, but can you tell something else?
Exactly. So what should we do regarding angle correction, especially in the intracranial vessels? The dictum is you never do angle correction whenever you're diagnosing something. Let's say I'm diagnosing vasospasm in a patient with SAH, and most of my values which are in the literature are based on TCD. TCD does not take angle correction into play. So if I am putting my patient into a vasospasmic category, looking at a value from the literature, that means my TCCD value also has to correlate with that. So I should not angle correct it, provided if you are diagnosing it based on the literature review. provide the other scenario. Let's say there is a stenosis and you want to diagnose whether there is a stenosis based on the flows. So it's not that you have Lindegaard's ratio and the flow velocities described in the literature specifically to diagnose vasospastic velocities in stenosis. So in that case, if you see a good segment of the vessel, let's say you see a segment of 1.5 centimeters of the MCA, in that case, if you can keep your angle correction less than 60, you can still appreciate a velocity which is much accurate in such patients. So if unless until you visualize a good segmental length of an artery and you keep the angle corrections to less than 60, because the cos 60 more than 60 would generally give you an abnormal value. And if you estimate velocity with whenever you see a segment let's say 1.5 centimeters and you estimate it with an angle corrected value, you generally end up overestimating the velocity and you get a higher peak velocities, which is incorrect. So it is advisable to do it when you are suspecting some amount of increase in velocity because of any secondary pathologies, apart from the ones, especially in SAH, where most of our values are based on TCD. So it is not advisable. Whereas in aneurysm, if you see that there is some amount of aliasing effect on a segmental length of a vessel, let's say the entire MCA starting from M1 and M2 is showing aliasing, and you put your Doppler window and you assess the velocities, and if the velocities, if you in that region you can still correct the angle because you know that there is an aliasing effect to the entire segment. So you can angle correct at each segment and see which segment of the vessel is having vasospasm. Is it the M1 segment or the M2 segment? So in this case, it is a regional velocity of the segmental artery. So I would say only you do it when you look at it in a broader picture where you can see a much vessel which is seen very well, and you suspect that there is a spasm at different segmental level. Whereas in TCD, it's a generalized value. The MCA mean velocity greater than 200, 250 is an established value in TCD, but that might not be the case when you're using TCCD, when you're diagnosing a segment which is congenital vasospasm rather than the entire
Yes.
artery.
Yes, yes, right. That's
We
true.
discussed a lot about this during your stay in Italy,
Yes.
and but I mean that TCCD is a new paradigm
Yes.
in the evaluation of vasospasm, and there is a no little short experience in our countries, in Italy, and but also in all the world. So it's important to discuss about this new paradigm of the monitoring of vasospasm, especially in ICU.
Professor Vincenzo, I want to ask you one thing regarding the difference of TCCD findings in a case of focal stenosis, as you have shown in the picture, and in cases of tandem lesions or a long segment stenosis.
Yes, good question. We have with the TCCD the morphology now, so we can see the segment, and we can distinguish between stenosis less than 5 millimeters and more than 5 millimeters, for example. This is a new classification of stenosis, and also the velocity are different in these cases, because when you have a long stenosis, probably at the distal segment, in the distal segment, the the velocity drop out. And so there is a concern about the peak, only the peak consider it's not the best way to define stenosis. So the best way is to try to have a ratio between stenosis and post-stenosis segment. So it's a good question, but it's difficult today. At now, we have the main classification are distinguish this focal stenosis with a big acceleration and long stenosis with not so without acceleration, relevant acceleration, but with a dropout in the velocity at the distal segment. So it's interesting.
Thank you for that. One more thing regarding venous Doppler. So what presets do you use for this venous Doppler? Intracranial.
For intracranial, the setting is we use a low flow setting. It's named low flow setting. We need to regulate PRF, pulse repetition frequency low. Also filters we need to regulate to low. Because if I put if I want to evaluate a vein with a low velocity with a high filter, I cut the low flow velocity so I can see the vein. And another setting is the box, the color box, small as possible.
Thank you. Do you follow any particular criteria for diagnosing intracranial stenosis, MCA stenosis or something? Or do you just go by the flow velocities, high flow velocities? Is there a pre-stenosis ratio? Do you follow that? Or pre-stenosis to pre-stenosis ratio? Or difference between inter-hemispheric difference? All those things.
Yes, the first evaluation, the first parameter were many years ago the opposite side when it was less than 30%. That was a stenosis, and but now. The criteria are 220 centimeters per second is one for peak systolic velocity is a good parameter for MCA. But it's important also ratio. Also ratio like the Nashet criteria, like Nashet criteria for carotid stenosis.
Carotid, yeah.
It's similar. It's similar. There was another study, the VASIT study, that have another parameter, the proximal velocity. But now it's preferable to choose the distal segment to have a comparison of velocity.
Dr. Pramod, one thing regarding ONSD.
Yes.
Do we have to measure in both planes, like vertical as well as axial?
Yeah, very good question, sir. Thank you. So most of the literature has measured the ONSs in the transverse plane. There are few studies which have taken an average of the transverse and the sagittal plane, or the vertical plane and the transverse plane. But as per the latest guidelines, it is mandatory that you stick to the checklist and you measure it at the transverse plane. The dictum is that it need not be at the center. All that it has to give you is a clear image of the optic nerve coming out perpendicular to the globe, and a good visualization of the optic nerve sheath. That is the dictum. So unless until you get a good imaging, it's not a hard and fast rule that you have to keep it in the axial or sagittal. Sometimes, let's say you are unable to appreciate well in the horizontal plane, you can still go ahead and look at it in an axial plane, provided you get a good visualization of the nerve and the sheath. So the endpoint is going to be an important thing rather than what we do at the beginning.
Okay, thank you. Dr. Ashish, madam, shall we take questions from the chat box? Are there any questions? Yeah, you are mute, ma'am. There is a question: how can we incorporate TCCD in a general intensive care unit? Pramod, can you answer it?
General intensive care unit, it does depend on what for let's say what you're trying to use it. Is it for prognostication or diagnostication? Like most of the let's say prognostication or therapeutic based TCCD have been there is literatures have been with acute liver hepatitis of acute liver failures, and especially and also in sepsis. And if you'd ask me, they have also studies which where they have used TCCD in preeclampsia and eclampsia patient. I'm not exactly sure how exactly they have used it, but there are studies on looking at the cerebral hemodynamics changes in patients with sepsis, in patients with acute hepatitis and hepatic encephalopathies, and also in patients who are on ECMO. So the cerebral perfusion pressure has a good correlation with ECMO. I mean, the uh, Doppler spectrums of the intracranial vessels have been assessed, especially in ECMO, to know the outcome of these GC, especially with the GCS aspect, how exactly these patients would probably wake up, or what is the prognostication purpose. It's also been used in patients who are on the ECMO. So basically, it need not be just about the brain. It can be any other organ dysfunction, but still you end up having some dysfunction in the brain can be looked at using the TCCD. So any deviation from the normal probably would tell you that there is some amount of pathology which has caused it, be it anywhere. Let's say there is a patient with hepatic failure or going into hepatic encephalopathy. You probably have done a baseline TCCD on this patient, and you see the patient worsening, and you can correlate those findings with your cerebral venous or arterial Doppler. Would probably definitely able to appreciate certain changes.
Yeah, thank you, Tom. Professor Vincenzo, would you like to add something on this? In other settings, would you like to use TCCD?
In ICU?
In general, yeah. In general critical care or something?
But TCCD is a good choice for a clinic, for a neurologist, for a intensivist, and also for other specialists. Now, for example, in our stroke unit, but endorsed by European Society of Neurosonology, we aim to incorporate the echocardiography in the stroke unit. And recently we organized a meeting in our region about this, the stroke, the echocardiography in a stroke unit from neurologists. This is another example how this is not TCCD, but ultrasound. It's a point of care ultrasound. And so point of care in ICU maybe the midline shift, or the other monitoring this is the victory of TCCD, the capability of monitoring.
Definitely, sir.
In every setting, also in emergency room.
Yeah, I would like
Yeah.
to add
Yeah, go
on.
ahead. Yeah.
Most of the transcranial Dopplers, TCT or TCCD, have been extensively researched in neurological and neurosurgical patients. So in other modalities, especially in the general ICU, it's more of a research-oriented topic, especially when you say preeclampsia or eclampsia or an hepatitis, or even for that matter in post-cardiac scenarios or during CPR. There are studies where they do it, they try to incorporate looking at the TCCD velocities or the TCCD patterns during the resuscitation to see how effective the resuscitations were during CPR. So this is an area of research probably people in the general intensive care unit would be more aware of.
Thank you. Professor Vincenzo, you told about the MES. In your case, there was a signal of microembolic signal. So would you like to elaborate more whether TCCD or a TCD would be a better choice to evaluate MES, or is it an incidental finding? How is?
Allora, for my evaluation, our evaluation is without TCD monitoring. We don't perform because we have no device to perform monitoring, long monitoring of transient of microembolic signals. So we use always a TCCD for evaluation, but it's incidental. In an acute patient, this is a short examination, and during the examination,
During that.
for example, in patient with the carotid stenosis, or like in our case, first cases, intracranial stenosis, you can see it's easy to have a microembolic signal. But in my experience, I don't perform at now the monitoring of microembolic signals. It's interesting.
Thank you so much. One
Yeah,
good
just add
point,
on.
Dr. Okay, go ahead.
Would you like to add something, sir, or it's
No,
okay?
no, go ahead.
So the microembolic signals, the diagnostic part of diagnosing a microembolic signals using the TCD is that you need to do a 40 minutes evaluation, putting the patient on the helmet and see for microembolic signals. But in a case of TCCD, let's say a patient has come to us and you see a microembolic signal for whatever reason, be it you are lucky or a 1 in a million chance you see it. So it is bound to the it's much that we have to evaluate such patients to look for the cause for such a microembolic signal, because we are not sure whether it is an exact spontaneous or some sort of atherosclerotic or some valvular disease. So we might have to evaluate such patients invariably when we see it on the TCCD. Whereas with TCD, you always have an option to point out, yes, this is an abnormal MES, but we don't with respect to TCCD. When we look at it, we need to evaluate whatsoever the reason is.
Yes. This is correct. This is correct, because I can distinguish between artifact, sure, with artifact between microembolic signal. But in my experience, in a patient, in acute patient with stroke and carotid stenosis with floating thrombus or intracranial stenosis, the microembolic signals are visible on TCCD only in the first stage of the pathology.
Yes.
After clopidogrel, after load
Antiplatelets you start.
aspirin,
It disappears.
they disappear. Yes. So I think that are microembolic signals there.
Right. Okay. One good point here I want to make here, Professor Vincenzo told clearly that leptomeningeal collaterals has to be evaluated. Increase in PCA velocities as compared to the mean flow velocities of the MCA, which is very important. It tells us the leptomeningeal collaterals or transcortical collaterals through PCA territory has increased. So this applies for our cases also, when we see a lot of cases of vasospasm, which are very severe vasospasm. Still, the patients do not present with any significant abnormality. Then we should evaluate. Complete set of evaluations should be done in these cases, including the PCS. Yeah, that's a good point. I think any more queries? Yeah, Pramod, you want to add anything, or do you want to ask?
I would probably like to enumerate certain limitations, let alone just talking about TCCD and its users. We should be aware of the limitations as well. So most of the time, it's the fatigue. You can't do TCCD for a long time. So it is always at that juncture when you do TCCD, you get certain values. So it's not a continuous monitor. You can't monitor continuous autoregulation like that of TCD on a TCCD. You can't monitor continuous ICP like that of an invasive ICP on a TCCD. So it is
Right.
always at that juncture, at that point. So it is always mandate. It's we should make it a mandate that we try to repeat it more often as possible to see whether therapeutic purpose or for diagnostic purpose when we are using it. And it's more of it does have a steeper learning curve, so you need to try and keep doing it day in and day out to get familiar with it, especially with the settings. And what do you do when you don't see something which you wanted to see? Is there anything that can probably make me look at it in a better way? So you can learn such things only when you start troubleshooting yourself, doing it more often every day.
Yeah. One last question from my side to Professor Vincenzo. Do you feel at any time, do you see any absent window using, and how do you tide over it?
Mm. The absence of window, the temporal bone window, is
Yeah.
a problem in old woman, especially in old woman. And
Yeah.
in this case, in the acute phase, especially in the acute phase, we use Sonoview, the contrast medium.
Okay.
If I have in mind that we have also angio CT. So in some
So yeah.
cases, it's not important to perform a TCCD at any cost. So
Understood. So you
in
can
this
go for.
case, when I can use Sonoview, it's possible, yes. But in other cases, there are also radiological evaluations.
Possible, yeah. Right. In the continuation of the same question, I want to ask, should we use contralateral side? If the contralateral window is good, should we use and comment from the contralateral side?
Yes, it's possible. Yes,
Possible.
yes,
Okay.
yes.
Thank you. Thank
Yeah,
you. Yeah.
I would like to
Okay.
add on to that regarding the contralateral window. Let's say there is a huge scalp hematoma here, and there is an EDH here, and I want to see what is happening in this MCA, but I don't have any leverage to do it because there is some sort of a wound or a scalp hematoma or some laceration. So I still do it through this window, provided you know how to use the depth and how to use the penetration, how to reduce the frequency, and how to reduce the PRF and increase the PRF to try to visualize the structures far off from your probe. So if you still are not convinced enough, I would probably ask the viewers to go back to the module 1 and see how exactly we can improve upon the images. How do we look at the images far off from the probe? The newer TCCD machines have an option even to reduce the frequencies to almost 1 megahertz or 1.5 megahertz to look at the farthest structure. And the softwares in such newer machines have evolved so much that you can still be able to appreciate the entire circle of the list just from looking at either side of the windows.
Okay. Thank you. Thank you, Prabhu. Uh, I don't have any further questions. I think we have come to the end of this beautiful, lucid presentation. And now I hand over to Ashish Madam to say a few words on this.
Yeah,
Thank you.
thank you so much. It was such an elaborate session, and probably, it is going to benefit so many viewers because it's beginning of practicing more with TCCD and taking the advantages of TCCD over TCD. So probably, I'm really glad, and it was a very nice, interactive, fascinating session with all good videos and high quality discussion. And I thank you all the presenters, especially Professor Vincenzo, for his time and for his knowledge shared with us. Thank you very much, Professor. And thank you, Pramod, for presenting. And last but not the least, Rajiv, thank you for moderating it in such a nice fashion and bringing out all the relevant and practical points, discussing each of them very patiently. And thank you very much, all of you.
Thank you.
It's been a pleasure, and thanks for this opportunity.
Thank you so much. Pleasure
Thank
is
you.
all ours. Thank you. Thank you for your time. Yeah, bye bye. Thanks.
Thank
Goodbye.
Bye.
you.
Thank
Bye.
you. Bye bye, guys.